Respected teachers, seniors and my dear friends. So as the conference brochure says, how short is really short and when should we act? So talking about Gulliver, it's actually a perspective. Till Gulliver came to their land, the Lilliputians thought that all of them are normal. So actually when we hear this story, we feel it's just a story. But see this girl came to us last year and she told she wanted to grow. But she was 18-year-old. She wants to grow desperately. When we took the x-rays, all epiphyses are closed and the final height is only 125 centimeter. So I was also surprised. I asked her why now you are very much worried about the height, because you were short before also. So she told in the school there were children of her height every time. Maybe they may be in the lower class, but she never felt she is abnormal. But at 18, when she finished the plus 2 and joined the college, she found out that she is abnormally short. So we have to find out short stature very, very early. This is a place in Nigeria. There was a nursing sister called Margaret Woodland and a pediatrician, Dr. David Morley. Now you know what is important.
And he has developed
this. So they developed this idea of road to health chart and the under 5 clinic. So this was how they did this. They had a spring balance and a chart was fixed on the wall, and the mothers were taught to put points or dots in their chart, and they were monitoring how the dot progresses. So if the dot is progressing this way, that is upwards, it is good. If it is parallel to the ground, it is danger, and if it is going down, it is very dangerous. So it was a very easy way of growth monitoring which was taught to those illiterate mothers in 1950s. And later in 2000 this paper came which told that growth monitoring has the potential for significant impact on mortality even in the absence of nutrition supplementation or education. Just telling the mother that your child is not growing well improves the outcome. And we can see that in the antenatal life, from a 130 micrometer long zygote, we get a 50 centimeter long child, or weight is like 10 microgram to 3 kg. Then in the early years, the weight doubles by 5 months and triples by 1 year, gains around 8 to 9 kg, and length gain is to the tune of 25 centimeters. And in the second year, weight gain is again 2 kg, that is 2 kg only over 1 year period, and length gain is 12.5 centimeter. And as pediatricians, that gives us an input that we need not force feed toddlers. The thing is, because as the growth rate is coming down, they are supposed to eat less. So that is why the child doesn't eat well and the mother comes to us. We can just reassure. And in the preschool years, the height gain comes down further, like 6 to 8 centimeter every year, and 5 years till puberty, the height gain can be like 5 to 6 centimeters every year. And there can be a nadir just before the onset of puberty, and that can be as low as 4 centimeter. But when you are seeing such a nadir, you have to wait for a spurt in the next year. If that spurt is not happening, then it is something abnormal. Having charts like this will always help us to find out what is the pubertal stage, because the window of growth ends with the onset of puberty, and the growth which happens during puberty in the 2 years is called the growth spurt, and that is the last window for a child to grow. So we have to monitor the pubertal status also. We are supposed to identify whether the puberty is early or delayed. Early puberty means breast stage 2 before 8 years in a girl, or genital stage 2 before 9 years in a boy. Breast stage 2 means the areola becomes prominent, and genital stage 2 means the testis size increases or the scrotal size increases. Testis size more than 4 ml indicates that genital stage 2 and puberty onset has happened. And menarche happening in a girl less than 10 years is also considered as precocious puberty. It is called a late when breast stage 2 doesn't appear in a girl even if the girl is 13 years, and genital stage 2 doesn't appear in a boy of 14 years. Another common complaint with which the boys are brought to us, prepubertal boys, the complaint is like they are having a micro penis. Most of the time the parents concentrate only at the penile size. They don't see the fat all around. They don't see the lipomastia. They don't see that the child is having a large tummy. And when we stretch the penis, we see that it is a buried penis rather than a micro penis or a small penis. And when you say micro penis, it actually depends upon the age group. In a newborn or even up to 6 months, a size less than 1.9 can be taken as micro penis, and a prepubertal child who is more than 5 centimeter, a size less than 4 centimeter is considered as micro penis. And also remember, the growth differs in adolescent age group. That is, the growth spurt occurs in girls early, that is due to stage 2 and 3 of Tanner, and in boys it is stage 3 and 4, and that is why girls start growing early, but they start from a lower platform, so their spurt is limited. Boys start from a higher platform, they grow a long years, and then they end up at a higher height. And the height gain which is expected in girl during puberty is almost 25 centimeters, and boys it is 28 to 30, but unfortunately our children has a blended pubertal spurt. When to worry, or how short is really short? Is shortest in the class a problem? Not always. I was the shortest in all my school classes, and too short for basketball. If Amitabh Bachchan's son is short for basketball, then that is a problem. So always take it in the parent's perspective. Somebody who is shorter than her younger sister, that is the time when the alarm should bell. You have to evaluate such a child. So this girl is the elder sister and she is short. She needs to be evaluated, and we evaluated her and found out to be having growth hormone deficiency. So the most critical factor in evaluation of growth problems is actually height velocity. So for that we need to monitor growth. So as a pediatrician, it is our primary responsibility to chart growth, to record growth and chart it in a good growth chart. And crossing of centiles is the simplest way to identify growth failure. When you are charting the growth of a child, you can very well see that a 10 centile child will grow in the 10th centile till he reaches puberty. A 50th centile child will grow in the 50th centile, 75th centile child will grow in the 75th centile. If he is coming down, then there is a problem. Then another clue is weight for height. Weight for height, if the weight is more affected, then it is mostly systemic disorders or malnutrition. If height is more affected, then it is endocrine problem. So to find out whether somebody is too short or too tall, we have to find out the exact age, that is not the age as reported by the mother. We have to find out what is the birth date, and then we have to calculate the age in completed months, then chart it in the growth chart, otherwise it is useless. Then mid-parental height we have to calculate. There is nothing like assume the height, like mother says that the father is 5 centimeter tall or something. We have to measure and then only do that. And sexual maturity rating is important, as well as bone age assessment. Bone age assessment should be taken as part and parcel of clinical examination. So that should be the first investigation we have to do. So we have to measure the child, measure the parents and plot in an appropriate growth chart so that we get a growth chart. Then when to refer or when to evaluate? When the length or height, weight or head circumference is below 3rd centile or above 97th centile on growth chart. When there is crossing of two major centile lines or a child is well below the mid-parental range, we have to evaluate. A weight loss or lack of weight gain for a month in the first 6 months, absence of weight gain for 2 to 3 months from 6 to 12 months of age, a child who is having micropenis, undescended testes or ambiguous genitals need evaluation for short stature. And length or height between 3rd centile, again crossing of two major centiles or child who is below, we have to monitor again. And between 3 years and 9 years, any child who developed pubic hair or breast budding, we have to be cautious. This could be a precocious puberty. And likewise, you have to examine the genital growth and testicular enlargement in a boy. If it happens before 9 years, that could be a sign of precocious puberty. Children with craniospinal irradiation or surgery for brain tumors should be monitored for growth, and children with micropenis should be evaluated at any age. If there is an arrest at the same stage of puberty for more than 2 years, that child needs evaluation, because usually from thelarchy to menarche, the usual time is 2 years. The maximum waiting period is actually 5 years, but usually it happens by 2 years. Then the child with micropenis, unilateral or bilateral gynecomastia in boys, and delayed puberty, that is girls, no breastfeeding by 14 years or no menarche by 15 years, and boys with no signs of puberty by 16 years. There could be some telltale signs, like in this child who is having a upper arm which is short, that is rhizomelia with a box shaped hell. This child was having achondroplasia. So this is a boy who is having some amount of webbing with a pectus excavatum. This could be a Noonan. You have another child who is having a short fourth metatarsal, that this could be a Turner or a hypoparathyroidism. And you have a child with a lot of teeth, that is crowding of teeth, could be a hypopituitarism. And these are some clues which tells you what is the diagnosis. Like when somebody is underweight, it is mainly nutrition. Overweight, it could be Cushing's or endocrine problem. Pallor, nutrition, or thalassemia, iron deficiency. Iron deficiency can cause significant short stature in our children. Then look for any telltale evidence of a growth hormone deficiency, hypopituitarism, like midfacial hypoplasia. And always see the blood pressure of a child who is short, because it could be a part of a chronic renal disease. Then micropenis and pubertal staging is also important. I will skip this because we are having less time. Like in bone age assessment, the method of bone age is number of carpal bones minus 1 is wrong, and always ask for an X-ray of the left wrist with hand, AP view, and you have to score it using a Grulich-Pite Atlas or a Tanner-Whitehouse method. Now we have apps which are available in the Play Store. One such app is called Bone Age. It costs 999 rupees. You can download it, and each bone they will show. We can score each bone just looking at the X-ray, and we get a composite score, that is a computerized system. It is mostly reliable. Many people are using it, but scoring one X-ray will take at least 10 to 15 minutes. At what age the child has presented with short stature? Like Kohlberg's model, ICP model for growth. If a child is short in infancy, growth failure in infancy is always nutritional. During childhood, think of hypothyroidism and growth hormone deficiency. During puberty, think of disorders of puberty. And when you are thinking about the causes of short stature, always think of the normal variants, which are called physiological, that is familial short stature and CDGP. Then you have many pathological causes, starting from undernutrition to endocrine condition to skeletal dysplasia to genetic syndromes. So CDGP means the growth velocity slows down during the first 3 years of life. That child is born normal, but they slows down both in height and weight. A normal or near normal growth velocity will be there, but below the lowest line, that is near the third centile or so. And during puberty, that child will not go to puberty along with the peers. There is a waiting period, and that is the time when the short stature is more exaggerated. We will see that the child is very short, and the clue here is the bone age will be delayed, but the delay in bone age will be to the tune of 2 to 3 years. Any delay more than 3 years, never think of constitutional delay in growth and puberty. More than 3 years is always pathological. We have to evaluate. And regarding the another normal variant is familial short stature, where here also the child is born normal weight and length. They cross down to their own genetic potential. That is, like we say, there is a catch up growth, there is also a catch down growth. So they have to come to their own parents' potential, and then they grow in that line. The bone age will be equal to chronological age. They end up short, but to the tune of the mid-parental height. But having said this, all short children who are having short parents are not having familial short stature. Some of you may be knowing this family. This child was admitted with dengue fever, this one, and we found out that the child is very short. Nobody had evaluated till then because both the parents are very short. So when we asked, they actually married in a meeting of short people, and unfortunately both of them were carrying a heritable disease. So it is actually a family of growth hormone deficiency, and now this child had become taller than the father with therapy with growth hormone treatment. And when somebody is having decreased weight for height, malnutrition is the most common cause of short stature. We have to remember that. And the clinically silent one, renal, GIT, that is celiac disease and all, we have to think about. For a short child who looks normal, these are the investigations which we have to do, the basic investigations plus a T4 free or free T4 along with TSH and bone age. So we can look for also for the vitamin D deficiency, a calcium profile, and if you are not having a facility for karyotyping, you can do an FSH, because in a pubertal child the FSH will be high, so there can be an indicator while you are waiting for the karyotyping. So this boy, 7-year-old boy, not growing well, good in studies. So when we plotted, this child is, this is the mid-parental height and the child's height is here. That means this child is abnormally short and this child needs investigation then and there. Unfortunately, because of financial reasons, they didn't investigate. We did a bone age. The bone age was actually 2.5 years in the 7-year-old child and height age was 3 years 6 months. So they waited, and after a period of another year also, the child had grown only 1 centimeter. So such are children who are having growth hormone deficiency. So careful selection of patients is very, very important, because growth hormone assay is not a foolproof test for growth hormone deficiency. If the patient is having other anthropometric characteristics like poor growth hormone, poor growth velocity and other telltale evidences, then we can select them for a growth hormone assay. We have to do multiple stimulated samples. Clonidine is the usual drug which we use, and we have to monitor the BP and never do a non-stimulated single value. Other methods used are insulin, arginine, L-DOPA and GHRH, seldom used. The recommendation says 2 standard provocative tests are needed. One test is sufficient in those with setting for growth hormone deficiency, that is somebody who is having hypopituitarism, somebody who had a CNS tumor, undergone surgery or irradiation. And in practice, a properly conducted clonidine test in a carefully selected patient satisfying the oxological criteria provides an accuracy of more than 85%. So all growth hormone test deficient patients are not having growth hormone deficiency. And always remember about sex hormone priming, that is any child who is more than 9 year or 10 year, it is always better to give a dose of testosterone and then only do the growth hormone testing. These are some markers of growth hormone deficiency like IGF-1 and IGF-BP3. IGF-1 can be used as screening test in older children, that is more than 5 years, and IGF-BP3 also can be used, but the assay is a little difficult to make available. So, regarding this children, can anybody say which of these is having Turner syndrome? Any choice? Postgraduates are here. So, actually both of them are having Turner syndrome. So, this is just to highlight that Turner syndrome can occur without any physical stigmata of Turner syndrome, and this is a study which was done in our clinics by Shankar sir, and we have found that 50% of Turner are being identified with amenorrhea by the gynecologist, and 100% of them are having short stature. So, all of them are passing through us and they reach a gynecologist for amenorrhea and they diagnose Turner syndrome. And very recently I had another experience. A child was referred to us, and when I asked for the reference, they told the tailor had sent the child to me because the tailor is stitching the uniform for last 2 or 3 years and the sizes are always same. So, he told better go and consult a doctor. So, many of these children are coming to us for many things, fever or whatever or vaccination, and we are missing them. So, the take home message is measure the height of children on well and ill visits, chart them in a growth chart. Only 30% of children with short stature has an endocrine cause. Think about CDGP and familial short stature before you embark on test, and be in the lookout for clinical signs and never hesitate to do basic tests. So, the most important thing is you should have a growth chart for each child. Thank you.